This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning we have our own Susmita Parashar is going to be presenting, and very much in tune with our events on Friday, where we had our Go Red with Women events on Clifton and Midtown campus. Susmita is going to provide us an update on women in cardiovascular disease. Susmita actually came to our faculty position out of our own fellowship program. Prior to that, she had actually been on faculty here in internal medicine. Susmita received both an MPH and a master's in clinical research during her faculty time. Is that never correct? And has a large personal interest and focus on women in cardiovascular disease, and is going to provide us the latest updates. Susmita.
Good morning, everyone. Thank you, Dr. Taylor, for the introduction. It's wonderful to be here, and I'm excited to present update on women and cardiovascular disease. The objectives of this talk would be to discuss pathophysiology of cardiovascular disease in women, coronary heart disease, discuss strategies to assess and stratify women according to their risk for CHD, distinguish gender differences in diagnosis and treatment of women. Now we're calling gender differences instead of disparities. Summarize recent guidelines and approaches to CVD prevention and approach to pharmacological intervention for women who are at risk for cardiovascular events. This is the slide that shows the global burden of disease study. And as you can see, in 1990, ischemic heart disease was number 5 on the list of killer worldwide. And in 2020, it's projected to be the number 1 cause of mortality worldwide. Heart disease, unfortunately, is still considered a man's disease. So when I was preparing the slides last year, I wanted to get pictures of heart disease in women. So when I looked at search for MI, heart attack symptoms, heart attack images, I got these pictures which are classic, men clutching their chest. This is a picture from Netter, person coming from restaurant after a heavy meal on a cold night, gets severe chest pain. So when someone had told me they couldn't find pictures of women with heart disease on Google. So I tried it myself, and this is what I found when I searched women and heart. Just a joke. Actually, heart disease is number 1 killer of women in the United States. It was featured in the Time magazine. The statistics is pretty staggering. Cardiovascular disease caused 1 death per minute among women in 2007, which is pretty amazing if you think that once I finish my talk in 60 minutes, 60 women would have died of MI just in the United States. Heart disease is leading cause of death of American women, killing more than a third, and more women than men die of cardiovascular disease each year. That represents more female lives than were claimed by cancer, Alzheimer's, and accidents combined. These are the age-adjusted death rates for American women in 2006. And as you can see here, in all the races, cardiovascular disease, specifically coronary heart disease, is number 1 cause of mortality. These are the breakdown for men and women for cardiovascular disease from 1980 to 2007. And although the rates of heart disease mortality have decreased in 2007, you can see that women are dying much more than men with heart disease, cardiovascular disease. This is a study that just came last week, which, knowing the statistics, 15-year trends in awareness that heart disease is the leading cause of death in women. And as you can see here, in 1997, only 33% of white women knew that heart disease is number 1 killer. It's increased to 65% in 2012, thanks to Go Red for Women campaign and several other campaigns all over the United States. But in blacks and Hispanics, only about 1/3 of women know that heart disease is number 1 killer, which is pretty amazing to me. Once women have coronary artery disease, they have worse outcome. So if they have MI, the risk of mortality is 1.5 times compared to men. When they have angina, the risk of morbidity and mortality is twice that of men. After bypass surgery, they have twice the morbidity and mortality. And heart failure incidence is about twice in women compared with men. This is the study, the National Registry of MI, 1994 to 2002. This is one of our publications in New England Journal by Dr. Vaccarino and us. About more than 500,000 ideal candidates for treatment were enrolled in the study after MI, and we did gender and racial comparison. We found that there was increased hospital mortality in women compared with men. The greatest disparity was in black women versus white men. They had 11% higher mortality. The disparity was lesser among white women and black men. This was one of the landmark studies by Dr. Vaccarino, who showed that younger women are the ones who are at really the highest risk of mortality after MI. They were twice as likely to die compared with younger men. And you can see here, this is the group that we're talking about, less than 50 years of age. The mortality is about 6.1% versus 2.9% in men. When we get older, our risks are pretty much similar to that of men. This is one of the studies in stable angina, and I just wanted to show that this is the differences in outcome is not just only in post-MI cases, it's also in stable angina patients. Women have twice the risk of death and non-fatal MI compared with men after adjusting for all the comorbidities, LV function, CAD severity, treatment, as well as revascularization. Are there any differences in treatment? This is one of our studies published in Circulation Outcomes, and these are about 1,900 patients enrolled with acute MI, and you can see here that women are less likely to receive aspirin, ACE inhibitors, beta blockers, even reperfusion, and quality of indicators when pooled, women are less likely to receive quality of indicators compared with men. The sex and racial differences in management of acute MI, unfortunately, have not narrowed in recent years. This is one of our publications in New England Journal of Medicine. And as you can see here, among all the three groups, this is white men, white women, black men, black women. And you can see that in each racial group, women are less likely to receive treatment compared with men. This is one of our papers that just got published last year. We enrolled about 2,000 patients with MI in the National Registry, 19 sites, and you can see here that women are less likely to participate in cardiac rehab at 1 month after acute MI. Even in Europe, it's not only in the United States. The purpose of showing this slide is that even in Europe, in patients with stable angina, women receive less exercise EKG testing, less coronary angiography, less statin and antiplatelet therapy, and revascularization is also less likely to be received by women. Why is it so? I have not met during my entire training and being on faculty anybody who says that, well, she's a woman, I'm not going to give her aspirin, or I'm not going to give her, get her cath or a statin. So why is it that women are less likely to receive treatments that are so pertinent to these patients? Is the pathoanatomy different? So I want to take a few moments to discuss that. This is a vulnerable vessel with a thin fibrous cap and a large lipid pool. When there are trigger events such as emotional stress or physical activity, it ruptures, leading to a thrombus formation and acute coronary syndrome, as you can see in the cath film here. The pathology of ACS may demonstrate plaque rupture or erosion, as we found out recently. There can be a thin-capped fibroatheroma with severe intraplaque hemorrhage, as you can see here, which is more common in older women. Now, this is pretty much similar to the pathology in men. In younger women, however, what people have found, is that there's a very thick capped erosion that happens, which leads to acute MI in these cases. These are the incidence of culprit plaque by sex and age in men. And as you can see here, even in less than 50 or more than 50 years of age, acute thrombi is caused mainly by plaque rupture, which is represented in yellow here in both these groups. In women, however, in less than 50 years of age, look what's going on. Most of the cases are due to plaque erosion, very little because of plaque rupture. In older women, however, plaque rupture is a more frequent etiology. In the Y study, the Women's Ischemia Syndrome study was an important study because this enrolled women with chest pain and myocardial ischemia documented by non-invasive testing. Half of these patients had no flow-limiting coronary obstructive disease at angiogram. And interestingly, they kept on having persisting symptoms, and subsequent significant occurrence of coronary heart disease was evaluated and looked at. They found that women with persistent chest pain, even without coronary obstructive disease, had worse cardiovascular events, as we'll see in this slide right here. So this is the group with significant coronary obstruction, more than 50%. 13.6% of patients had MI or death, and 2.5% who had no coronary obstruction, less than 20%, had events. So this is important. This is not zero. So it's important to know that just because the coronary cath does not show obstructive disease, they will have good outcomes. They continue to have somewhat of a worse outcome. So I want to just change the gear a little bit and talk about Dr. Furchgott. So in 1970s, Dr. Furchgott technician was unable to vasoconstrict the vessels with acetylcholine. So what's the next step? Fire the technician, retract his publications, or investigate. So he decided to investigate, thankfully. So what he found, and his group, that when you take a smooth muscle cell and you subject it to acetylcholine, if there's an intact endothelium, there is vasodilatation. However, if you strip the endothelium off and you subject this to acetylcholine, there is no vasodilatation. There is actually paradoxical vasoconstriction. So he discovered nitric oxide. So in intact endothelium, acetylcholine releases nitric oxide, which causes vasodilatation. But without intact endothelium, there is no nitric oxide, so there is, in fact, paradoxical vasoconstriction. It's great that he decided to investigate that because he got a Nobel Prize for Physiology in 1998 for this paper that's right here, the obligatory role of endothelial cells. And this is all the 3 people who received the Nobel Prize. So what's the clinical significance of that? Why are we talking about it right now? So this is one of the landmark papers, and you can recognize one of the authors here, Dr. Alexander, is that there is paradoxical vasoconstriction induced by acetylcholine in atherosclerotic coronary arteries. You cannot see it very well here, but this is a regular baseline cardiac cath, and you can see with acetylcholine, it just becomes like a string. This has led finally, after several years, a functional angiogram protocol where patients are given, after adenosine, increasing doses of acetylcholine followed by nitroglycerin, followed by an ultrasound to look at endothelial dysfunction. This is one of my patients who was 38-year-old who kept coming to me with right arm pain, which was squeezing right arm pain with exercise. I did a stress test, which was normal, but she just continued to come. She was a runner, and she couldn't run anymore because she got this extremely squeezing chest pain with exercise. So this is a baseline. How am I playing here? Don't click. Okay. This is a baseline cath film. As you can see, it looks pretty normal. There's no significant blockages. In the next one, concentrate on the proximal LAD over here. And you can see this is with acetylcholine, and you can see here that there's pretty significant vasoconstriction in the entire LAD, mainly in the proximal LAD. So based on this, we treated her with nitroglycerin, calcium channel blockers, not beta blockers, statins, and she's doing somewhat better now. This is a patient that most of us know in this room. She's a 50-year-old female with left ear pain on exercise and mental mental stress. She had normal stress tests. I even did a stress MRI on her looking for endothelial dysfunction. Absolutely, they called me from the MRI lab that it looks beautiful. That was the report. So this is the baseline cath that it actually looks absolutely beautiful. So with increasing doses of acetylcholine, this is what happened. So there was severe left main spasm, which led to this on the table. And she had a cardiac arrest. She was resuscitated, and she, after several days of going back and forth, what needs to be done for her, we ended up placing a defibrillator for her. So she has been, we all have taken care of it, I and Chris Nell, primarily Dr. Sperling. It has been extreme, one of the most challenging patients. Dr. Kayumi, who was here, who was on service at that time. It has been extremely challenging to take care of her. So endothelial dysfunction is the risk factors. Its predisposing factors are hypertension, hypercholesterolemia, age, diabetes, drug-eluting stents, inflammation, oxidative stress, and smoking. This endothelial dysfunction is the risk factor for now known for stroke, TIA, angina, MI, sudden cardiac death, renal failure, metabolic syndrome, claudication, erectile dysfunction, and latest it's also a risk factor for diastolic dysfunction as well. The interventions that improve endothelial dysfunction and clinical outcomes are lipid lowering. Statins are the only drugs that are actually known to reverse endothelial dysfunction. ACE inhibitors, ARB helps, calcium channel blockers. Glycemic control in diabetics is very important. Blood pressure control, weight reduction, exercise, and PDE5 inhibitors are also known to help these people. So once we have looked at difference in pathoanatomy, let's look at the different risk factors that may be more common in women compared with men. There are several, when we look at CHD outcomes, there are conventional risk factors such as smoking, diabetes, hyperlipidemia, sedentary lifestyle, and hypertension. There are some emerging risk factors which are listed here, including inflammation and oxidative stress. Then there are some other psychosocial risk factors, depression, stress, and access to care that are very important, as I'll present. This is the 2011 update on the guidelines and prevention of cardiovascular disease in women by Dr. Mosca, which is a good resource if you would want a reference. When we look at the characteristics between men and women, this is again our publication looking at MI patients in 19 US sites. You can see here that women are more likely to be, these are all acute MI patients, women are more likely to be older, and they're more likely to be African American, less likely to be married, working full-time, and less likely to be educated. They're also more likely to have hypertension and diabetes. So they have higher comorbidities compared with men. When we look at the avoidable risk factors, they have higher cholesterol level, worse physical inactivity, they're more likely to be overweight. When they have diabetes, diabetes is found to be a more powerful risk factor for coronary heart disease. They are 3 to 7-fold in women compared to 2 to 3-fold in men. So if you have diabetes, women are at a higher risk for developing coronary artery disease compared with men. HDL cholesterol, lower levels are more predictive of coronary artery disease in women. And despite all this, we counsel women less about nutrition, exercise, and weight control. At least that's what's been documented in the charts. When I see patients in clinic who want risk stratification, I'm using Framingham Heart Study, and there are a lot of apps that come can be used on the phone, especially iPhone. They're very, very user-friendly to calculate the Framingham Heart Study. However, Framingham Heart Study has several limitations. There is a very narrow focus on only short-term 10-year risk and on only MI and CHD death. What's important for me is that it lacks the inclusion of family history, which is so important. If a patient comes with 3 members who died of MI at age 40, I'm not sure if I'll believe the Framingham risk score of 2% in those patients. It overestimates or underestimates the risk in non-white population, and subclinical cardiovascular disease can have relative high prevalence among women who are scored as being at low risk by Framingham risk score. These are the latest risk stratification guidelines. These are the patients who are considered to be at high risk for coronary artery disease. If they have documented atherosclerotic disease, coronary heart disease, cerebrovascular disease, peripheral artery disease, as well as aortic aneurysm, diabetes, kidney disease, and 10-year Framingham cardiovascular risk score of more than equal to 10%. This is new in the guidelines in 2011. These are the women who are at risk. We know most of these. What's important to know, as I just mentioned, is that premature cardiovascular disease in a first-degree relative with less than 55 years in a male and less than 65 years in a female is considered at risk. These are the new addition. Women with SLE, lupus, rheumatoid arthritis, women and men are considered to be at risk. A history of pregnancy-induced hypertension, gestational diabetes, and preeclampsia is important. So now I definitely ask women about these risk factors when I see them in clinic. This is the ideal cardiovascular health, and you can see all the numbers here. We know them. Ideal patients are rare in most clinical practices and make up less than 5% of women in most studies. So once we've talked about the conventional risk factors, let's talk about some psychosocial risk factors. And the purpose of showing you this slide, the ST depression, is once I was giving a talk on effect of transient depression on mortality after MI. And after my entire talk, someone asked me a question, and they had misunderstood my entire talk to be ST depression. So it was kind of challenging to answer that question in a politically correct manner. But so I'm talking about depression now. So this is an inter-heart study which examined the importance of risk factors for incident MI. There were 15,000 first MI cases and about 15,000 controls in 52 countries. They looked at the risk factors for incident MI, and as you can see here, psychosocial risk factors were number 3 in the risk pertaining to the risk of MI. It was higher than diabetes and hypertension. So this has brought the issue of depression and social support issues to the forefront. I just want to take a couple of minutes to show you our studies that we've done. This was premier study, which was we enrolled acute MI patients from 19 US sites in 2003-2004. And we screened them for depression with a PHQ score. We actually use the patient health questionnaire in our preventive cardiology clinic. Every new patient fills this questionnaire. It takes less than a minute to fill this questionnaire. If the PHQ score is more than equal to 10, they have at least moderate depressive symptoms. We found that at MI hospitalization, 21% of patients had depression. At 1 month post-MI, about 14% had depression. This is one of our abstracts and paper that received the Best Abstract Award because of the significance of the findings that younger women are 40% of them are likely to be depressed compared with 22% of younger men and other groups. So when we did a multivariate analysis looking at all the risk factors, comorbidities, prior CHD, bypass, PCI, and clinical status on examination, on admission, we found that younger women were 4 times as likely to be depressed compared with older men, I apologize. So when we thought that, well, younger women are more likely to be depressed, so what though? Does depression contribute to their worse outcome after MI? So we looked at this study, which was published in Circulation Outcomes. We looked at 1 year post-MI rehospitalization rate by sex in the same study, and we found that women were more likely to be rehospitalized after MI compared with men. They also had higher risk of mortality compared with men after MI. Then we had a model where we added different covariates, adding depression towards the end to look at whether depression contributes to their worse outcome, and we found that the sex differences in outcome persisted after adding all the covariates, including prior CHD, diabetes, hypertension, all LV function. But when we added depression, there was no further differences in the outcome. So this led us to conclude that depression contributes to some of the worst outcomes in women post-MI. This is one of our papers looking at bypass patients with depressive symptoms, and we found that women with depressive symptoms have much worse functional status compared with men and compared with non-depressed women. So this has all these papers and several different studies done by very renowned investigators have led this AHA Science Advisory to make depression screening in CHD patients as a class 1 recommendation. And again, in our women's heart clinic and preventive cardiology, we routinely screen for depression when they come, every new patient. We looked at, again, other risk factors that may pertain to worse outcomes in women. This is one of our papers looking at whether if women have early menopause, do they have worse angina? And the theory was, the hypothesis was that maybe they have less time to have estrogen, and maybe that's why they will have worse outcome. And we found that women who have early menopause, which we define here as less than 40 years, had higher angina compared with women who had menopause more than 50 years of age. I want to also go to what about the symptoms? Like I said, most of women are not even aware that heart disease is #1 killer. So are they aware of the symptoms? What are the symptoms? Are the symptoms different? And this is one of my most challenging things that I do in the clinic, is that women come with all kinds of atypical symptoms, is to figure out whether it could be cardiac, non-cardiac, is it atypical, typical. That is the most difficult thing, challenging thing that I find in my clinical practice. So women may have typical symptoms that are common in men, which is chest pressure in the middle of the chest, that may be radiating with shortness of breath, that we know for everybody. What we have found, and other studies have found, that women may have milder symptoms. So they may not have chest pain. So if you ask the women, do you have chest pain, they will say no. But if we ask them, do you have chest discomfort or anything strange in the chest, anything that's different, then they may tell you about that. There may be a sudden onset of weakness, shortness of breath, fatigue, body aches, or overall feeling of illness without chest pain. There may be unusual feeling or mild discomfort in the back, chest, arm, neck, or jaw, which may be without chest pain as well. So it's quite challenging. As you can see here, these symptoms are pretty atypical and vague. This is the study that I found most interesting. They asked women whether they would recognize symptoms, what would they do? Only 53% of women said they would call 911 if they were experiencing the symptoms of a heart attack. However, 79% said they would call 911 if someone else was having a heart attack. So what's different here is women don't, I ask patients over and over and over again that why did you wait for 6 hours before you came to the ER, or 2 days, or a week? And they just don't want to come to the ER and be called crazy or having a panic attack or just being silly. When I talk to patients, I saw a patient who was a wife of a CEO of a very large hospital. And she said, he was telling me that she was having chest pain, severe chest pain. She didn't want to call 911. She called him to come home all the way, drive 40 minutes back and take her to the ER. She was found to have a massive heart attack and ended up having a bypass surgery. And these are just highly educated women who are very aware of all the symptoms, and they still don't want to seek care. So for themselves, 46% of women would do something other than call 911, such as take an aspirin, go to the hospital, or call the doctor, or call the spouse in this case. So this is my prompt to show you a video, which is called Just a Little Heart Attack. This is by American Heart Association, Go Red for Women.
It started out like a totally normal day. Okay, move objection deadline to the third line after survey. Oh, honey, for when you always use the verb start. What are you doing down there? Did you finish your breakfast? Ow. brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, get her. Nobody move. I'm getting a dustpan.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
Okay, so that's a good resource to give to women in your practice, and it gives a lot of, within humor, symptoms, atypical symptoms of heart attack that women should recognize. We'll try to look at how can we risk stratify women with MI. Why do women have worse outcome? How are the tests maybe different? So this is one of our abstracts that was presented at the ACC last year. We found that when we looked at the biomarker profile of younger women after MI compared with older, younger men, we found that women actually do not have worse inflammation compared with, they have worse inflammation here, but once we adjust for it, it goes away. So basically the conclusion of this study was that women have lower markers, including troponin, CKMB. They do not have higher inflammatory markers. So what does it mean? We're thinking in conferences and other people are putting heads together. Maybe the cutoff of troponin and the CKMB we are using for men may not be pertinent for women. Maybe we need a lower cutoff for women. So we don't have specific guidelines yet, and we need more studies to validate this data and to come up with guidelines whether we should be using different cutoffs for women compared with men in terms of cardiac markers. Assessing cardiac risk in women, as I told you, this is what's the major part of my clinical duty in the clinics. Assessing cardiac risk factors in women, I find it quite challenging, very interesting, but quite challenging. The most important factor that I have found to be useful is the clinical assessment. Assessing risk factors, assessing symptoms, stress testing, cardiac cath, CTA, and coronary calcium. I use all of these modalities to stratify women with, in terms of coronary heart disease. So this is a cartoon. I don't know if you can see it in there. Which diagnostic strategies do you use in women? The cartoon says the doctor says to go ahead and self-diagnose, which is pretty much what I would like to tell them, but unfortunately I have to come up with a plan which may or may not be, which may require some clinical judgment, as we have shown in the cardiac cath before. So this is from the American Heart Association Practice Guidelines in 2010, looking at pre-test likelihood of coronary artery disease in women. You can see here, this is actually looks kind of intimidating, but it's pretty simple. If they are asymptomatic, they don't need stress test. If they are young, less than 60 years of age, and they have non-anginal chest pain, they do not need stress test. But everybody else almost would be an intermediate category. And this is very important to know because of all the appropriateness guidelines that we have in place now. If they are older than 60 and they have typical angina, you can go directly to cardiac cath. The stress testing to use, there are three kinds of modalities: exercise testing, echo, and nuclear imaging. When a woman is coming with symptoms, intermediate risk category, they have good exercise tolerance and interpretable 12 lead EKG, and I have listed here what is uninterpretable. If they have WPW, if they have more than 1 millimeter ST depression at rest, left bundle branch block, paced rhythm, or LVH or digoxin, then this EKG would not be interpretable, and then you would not refer them to exercise treadmill testing. Everybody else, the guidelines is exercise treadmill testing. If they are, we calculate the Duke treadmill score, and if they are at low risk score, we give them medical treatment. If they are intermediate risk, we can do stress imaging. If they are high risk, then we would do cath, PCI, or bypass surgery based on what the anatomy is. Exercise EKG in women has the sensitivity and specificity, which is quite not great. Sensitivity is only 67% and specificity is 60 to 69%. In men, it's a little bit higher, but not really great. And why is that? It's because women do not exercise for as long as men most of the times. They may not have exertional symptoms that would be of low predictive value, like fatigue or shortness of breath. They have lower obstructive coronary artery disease prevalence, and they have reported high rates of false positivity. The strength is that pretty high accuracy in women with negative exercise EKG. So if a woman has exercises for 13 minutes or 14 METs, then I'm pretty sure they don't have EKG changes. It's pretty accurate that the negative EKG is actually true negative. This is again the algorithm published by AHA for evaluation of symptomatic women using cardiac imaging. So we've already dealt with this group, which is a intermediate risk group who are able to exercise. If they are diabetic, or they have abnormal EKG, questionable exercise capacity, or they have had revascularization before, then the recommendation is for pharmacological stress imaging. If they are able to exercise more than 5 METs, you do exercise or MPI or echo. And if they are unable to exercise to less than to 5 METs, then we would do pharmacological nuclear imaging or an pharmacological echocardiogram. If it's moderately to severely abnormal or there's a depressed EF, then we would go for cardiac cath. Stress echocardiography in women, I use that quite a bit because there is no ionizing radiation. There is added value of rest and stress, regional wall motion, and ventricular function. There is very minimal added cost. The reduced image quality can be a problem, especially in obese women, and that can be improved with contrast. So I cannot emphasize how important the use of contrast is to have maybe to echocardiography technician to use it if they cannot see the endocardium very well. This is the slide looking at the differences in comparing the sensitivity and specificity of exercise EKG, exercise echo, and dobutamine echo. And as you can see here, adding the echo part, the imaging part, greatly increases the sensitivity and specificity of an exercise testing. So in practice, I hardly ever use the exercise, just the treadmill part. I use it in very young patients who I know most of the time that they will be negative. I've been surprised, sometimes it's been positive, but those are the only patients that I'm using practically the exercise treadmill only. Most of the times I use an exercise echo or a nuclear if the suspicion is higher. For myocardial perfusion SPECT, there is a lot of published report. The technetium 99M decreases the breast tissue artifact. We can attenuation correct now, which gives us better true negative data. We can use the ejection fraction or wall motion abnormality, which reduces the false positive. The problem is that it gives radiation, which is 3 to 5 times the background level. And this can be a problem in younger women. So in younger women of childbearing age, I try to use a stress echo, and in older women or diabetics, I try to use the nuclear imaging. The sensitivity is pretty high, 85 to 90%. The specificity is 65 to 70%. As I mentioned, we use gated SPECT. We calculate the EF and wall motion, attenuation correction, prone imaging. All of these increase the sensitivity and specificity. At Emory, we also have PET. So that can be also used, which gives us a coronary flow reserve data, which is very important in these women. This is looking at comparing the sensitivity and specificity compared with the stress EKG. And as you can see, the sensitivity and specificity improve quite a bit after if you use the SPECT imaging. Cardiac catheterization has several challenges. Women have small caliber vessels, and there's quite a high prevalence of non-obstructive disease in these women. Coronary CT is another modality we have here, and I've used it a few times, especially in women who don't want to have a cardiac cath, don't want to have an invasive strategy. But I'm very suspicious that there is some obstructive disease, so I've used the coronary CT angiogram. In asymptomatic patients, which form some part of preventive cardiology women's heart practice, I use the calcium scoring, and it's kind of like a little bit of a cheat sheet for me. If they have really significant family history, but their LDL is 130, the guidelines don't recommend statin. But if so I may do a calcium score in these women. If there's less than 100, there is factor modification. If it's more than 400, I would consider a stress test unless they are totally, absolutely asymptomatic and running 4 miles a day without symptoms. If they have coronary calcium, which put them at a high vascular age, then I use statin for them as well. The update on guidelines, the treatment in ACS is pretty similar to men and women. There is special attention to anticoagulant dosage and monitoring in women because of their lower body mass index. In unstable angina and non-STEMI, in women with low risk features, a conservative strategy is recommended, which means that stabilizing them, maybe do a stress test, but not really rush them to cardiac cath straight away. These are the lipid targets in women: LDL less than 100, HDL more than 50, triglycerides should be less than 150. When we talk about statins, there's a lot of controversy in statins in women. A lot of patients look at these data, they come in the clinic and ask us about it. This is a meta-analysis of statin effects in women versus men. And basically this was a study that was published last year. There was a lot of news about it. The bottom line is that statins are as effective in women as they are in men. So statin works in women the same, so we should have no hesitancy in using these drugs. This is a study that just came last month, later last year. Statin use and risk of diabetes in postmenopausal women. I don't know how many of patients in your practice have come and asked you about it, but I've had patients come and bring me newspaper articles and printouts saying, why am I on statin? It will lead to diabetes. So this paper actually does show them that about more than 1.5 million women, that statin use leads to diabetes. And even after all the multivariable analysis, about 44% increased risk of diabetes compared with people who were not on statin. However, this was an observational study, and there are no guidelines right now which do not recommend women to be on statin. But this is something to look out for in the future as more studies come in. I sometimes use CRP more. I've seen outside practices, private practices use CRP, and women are referred to me, or they self-refer saying that my CRP is high, and what does that mean? So basically, if a CRP is more than 2 and there is no acute inflammatory process, in women more than 60 years of age, we may consider a statin. This is based on Jupiter trial. Aspirin, what's the role of aspirin in women? It is reasonable in older women more than 65 years of age, but not so much in younger women. In younger women, actually, it's a class 3 recommendation for primary prevention of coronary disease. Menopausal therapies, again, class 3 recommendation, antioxidants, folic acid, all of these are not found to be useful in women. But aspirin is important because I see a lot of young women on small dose of aspirin coming in that I promptly discontinue. This is a call of action paper that came out last year with women and peripheral vascular disease, that we need more studies and more guidelines to evaluate women with peripheral vascular disease, especially younger women. I want to end on a sweet note. So this is a study that just came out last month, that strawberries and blueberries decrease MI risk in women. So more than 2 helpings of strawberries or blueberries are supposed to decrease the risk of MI, and we certainly can do that. That shouldn't be a problem. We have a women's heart clinic, women's heart program in Clinic A and Midtown at St. Joe's, and we are very proud of it. We just started that last year. This is our group. The photo is not updated, but we have a very large list of clinicians and nurse practitioners who are who have an interest in women's and heart disease, and we're very excited about this ongoing program. We put a lot of blogs and interviews as well as articles on this website, so you could give this to your patients for a useful resource. I just want to thank you for your time, and I will take questions.
Thank you, Susmita, for a very broad-based overview of women and cardiovascular disease and a very timely update.
The preceding program is copyrighted by Emory University.